The functional reach is a quick, easy-to-follow screen to assess a patient's balance and functional mobility, which may be affected in a patient with neurological dysfunction. It is a performance measure appropriate for patients with possible neurological dysfunction because it is a test of functional mobility and balance, both vestibular and non-vestibular. It is assessing anticipatory balance and stability by measuring the maximum distance an individual can reach forward while standing in a fixed position. The only tool needed is a yardstick. The yardstick should be mounted on a wall parallel to the height of the patient's shoulder level using tape or Velcro. There is a total of 5 trials with 2 practice and 3 test trials. The 3 test trials are averaged for a final score. There should be a 15-second break between trials. The test takes about 5 minutes to administer. Remember to have the patient sit while you demonstrate and then guard the patient while they perform the exam. Be sure to use a gait belt. The patient is told to stand close to but not touching a wall with the shoulder at 90 degrees of flexion in a closed fist. The yardstick is at the level of their acromion and the starting position of the third metacarpal head is noted. Instruct the patient to reach as far forward as you can without taking a step. The clinician should record the end position of the third metacarpal head. If the feet move, the trial must be repeated. There is also a modified version of the test for patients who are unable to stand, which has been validated for subacute stage post-stroke. The patient is sitting in a chair, again with the yardstick at the level of the acromion. Hips, knees, and ankles should be at 90 degrees of flexion. The unaffected side should be near the wall, and the patient will lean forward. The measure is taken from the distal end of the third metacarpal. Another modified version for patients who cannot raise their arm is using the distance the acromion travels as the marker. Also, if they are unable to make a fist, the ulnar styloid process should be used. For healthy functioning individuals, a reach of 10 inches or more indicates adequate functional balance. If the person scores less than 6 inches, it indicates increased risk for falls. A score between 6 to 10 inches indicates a moderate risk for falls. For community-dwelling elderly, a functional reach of less than 7 inches indicates that they are unable to leave their neighborhood without help, have limited mobility skills, and are restricted in their ADLs. For frail adults, less than 7.3 inches indicates increased risk for falls. For patients in the subacute stage post-stroke, the norm for the paretic side is 0.64 inches and non-paretic side is 1.1 inches. For patients with Parkinson's, if they have a history of falls, they are likely to have a functional reach test of 0.6 inches or less.